just
Sure.
verify that you see it recording and all good?
Sure. So we're back with Eric Pahl, CTO and co-founder of OmniLife. Eric, picking up on our conversations around OmniLife and its stand for bringing better decision-making to kind of the organ transplant workflow. Would you first of all kind of explain for us clinical decision-making as kind of a framework and a practice?
So clinicians have procedures and protocols that help them navigate how to prescribe medications based on previous scientific medical literature, founded in randomized controlled trials and other studies that were done previous that have determined the physiological manifestation of disease, for example, for diagnosis, and then prescriptive processes that can go to reverse, cure those diseases, etc. It has to do with the clinician being extremely well-trained, as well as up to date with the recent literature, and also have their finger on the pulse, figuratively and literally, of their patient to understand their patient's medical situation, the data that they're presenting today, their family history from yesterday, in order to navigate all of those care pathways that were, illustrated in the literature. So we have a lot of pressure on our clinicians to handle all of these data, and also not only have access to all of the data, but also know all of the options as far as what's been done previously and what's been researched and proven in the clinical literature. So a clinician at any given point in time needs access to all of those access points and possible delivery mechanisms. So it makes their job very difficult, and that's kind of clinical decision support or clinical decision making in a nutshell.
Okay, and so so is there a particular guiding principle for clinical decision making?
So yes, so the clinical decision making, the clinicians will use literature that's been approved by or procedures and prescribed medications that have been ruled by the Federal Drug Administration, the Food and Drug Administration, the FDA, at the United States level. And in order for a company like OmniLife, we provide tools for clinicians, and one of the things that other tools in order to help clinicians, whether it's taking a blood pressure reading or assembling data or viewing data, need to be approved by the Federal Drug Administration. And the FDA has produced a rule for clinical decision support in our space at the time of clinical decision making, which is that if it can be assistive without being prescriptive and not be a medical device, but if the clinician were not to have, or were not able to see the raw data, then it would be considered a medical device. So, for instance, a computer scan in binary producing a disease prediction or a disease diagnosis is considered a medical device because the binary raw file is not human readable. But when if there was a calculator for BMI and the clinician had access to the height and the weight of the patient directly, they could use a automatically calculated BMI as a non-medical device because the patient or because the clinician has access to both the height and the weight raw files or raw measurements, and they're human readable. So that's the ruling from the FDA.
So how does that correlate or affect TXP Chad and Ask Alan from OmniLife?
Absolutely. So how it affects our clinical decision support, we provide tools for predictive analytics to surgeons and clinical teams at time of organ offer for transplant. And in our case, we predict a number of endpoints for the potential transplant. So at the time of a particular kidney offer, we can forecast based on previous data when that graft may fail or have complications for that recipient. And should they not get transplanted, how long that patient would last without a transplant before the next offer arrives, or the patient becomes too sick to transplant or unfortunately dies waiting for their next offer. In this case, we use data from the donor and data from the candidate recipient or potential recipient in order to forecast those. And it's a similar analogy to the BMI, where the surgeon and the clinical team have access to those human readable data files, but the data are vast, over 900 different variables, over 1,000 different variables, if you include some logistics as well, in order to make that decision that we process instantaneously. But the surgical and clinical teams do have access to the raw data in human readable format at that time. So we do not fall under the need for a medical device under the Federal Food and Drug Administration.
Great. So would you kind of take us through kind of clinical decision making, and perhaps with an emphasis on cognitive biases that are just inherent to clinical decision making, and perhaps what we do to offset it?
Absolutely. So behavioral economics has recently been a Nobel Prize winning category. Work from Richard Thaler, Amos Tversky, and I'm going to have to modify the manuscript so I can remember the last guy's name. Daniel Kahneman. Daniel Kahneman have kind of pioneered this industry. Prior to their work in behavioral economics, it had been thought that humans make their decisions, particularly in economics, and when the stakes are high, paying with dollars or paying with lives, we make our decisions rationally, in the form of having the relevant data quantified for us, and we weigh risks appropriately. 50% chance of this, 50% chance of this, 80% chance of that, 20% chance of this, and we can weigh those appropriately. It's their work that inspired governments, as well as different decision theories that are more applicable to social beings like humans, Homo sapiens, that do not, in fact, have those traits in their decision making. They are inherent to anchoring biases, and maybe I can go through a couple of them. So we have anchoring bias, loss aversion, and confirmation. There's another one. Confirmation bias as well, and recency bias as well. There are a number of different ones, but I can describe some of the studies. But I think maybe recency would be one that's good in this situation, for emergent conditions when there's not a lot of time, and loss bias, for example, too. So let's do those two. So from a loss bias perspective, it's been well proven that losing something is having all the equations the same. The cost functions are the same for both. When there's a perceived loss, it's weighted about 4 times more than a perceived gain. For instance, if you're given something that's worth a certain value, to give it up, you'll want 4x, which leads to a dichotomy when we're coming into, when we think of a traditional marketplace. So in terms of organ transplantation, the cost of losing a patient's life on the list by accepting an organ is actually 4 times worse than simply letting the patient expire without that transplant event. So the status quo is a bias 4 times greater than accepting on new risk or trading risks for a different one.
So that would be, here is an organ that is marginal in terms of its likely graft success. So you're saying that this bias would be to reject the risky organ and let the patient die on the wait list. Is that?
That's right. It's substantiated in the recent work in the American Journal of Transplantation, where they show the survival curves and the benefits of organs that were declined. Organs that, so in a traditional, in a totally rational marketplace, transplanting an organ with the same risk as dying on the list, or risk of that organ failing versus risk of the patient dying on the list, when they're the same.
Yeah.
There's a significant amount of organs that are declined, and nobody takes that risk. And then you get a little bit better. Still, most of them decline. A little bit better, and in this case, they're all staying at this 50% chance death at 5 years. And transplant comes along, also 50% chance death at 5 years. Almost none of those organs are transplanted. And then if it's 60% chance, still none of those organs are transplanted. 80% chance, still none of those organs are transplanted. But when you have to get 4 times better perceived gain in order to make that loss versus the offset. Yeah,
so
offset that bias. So
I'm sure some surgeons would say, yeah, that's right in theory, but we're better than that. We're schooled better than that. Speak to that. In terms of what the data of the clinical data says.
So in terms of clinical data sets, despite this being around this study and like public health analysis and survival analysis of all of these things, we still have 22 people dying every day. We actually have an increase in the number of organs that are discarded, or a percentage of organs that are discarded each year over the last 30 years. Each year after year after year, as we learn more and more about the benefits of, and as we show the survival benefits of people with transplants versus people that wait for a better transplant or expire on the list and die, we continue to have a larger margin of organs that are discarded, despite just the facts in the data. So we can say that, yeah, we're being more aggressive, but.
So could you also say that this is this is kind of the clinical application of the perfect being the enemy of the good enough, and that the data shows that good enough organs have far better patient outcomes than waiting for the perfect one or the near perfect one?
Absolutely. There certainly is the case that sometimes, in a very, very limited amount of cases, it would be beneficial to wait for another organ. But in most cases, in almost under any circumstance, taking the organ is better than waiting on the list and being on dialysis, et cetera.
Great. So how does the recency bias come into play here?
So the recency bias, and unfortunately, many transplant centers are small transplant centers and are heavily penalized for particular losses due to graft failure or transplants that did not go well. And in the case of dealing with small sample sizes, something that happened or a risk that was taken last month or last year that went poorly will impact a decision this year or next month. You won't make the same bet twice should things not turn out the way that you made where a clinician makes the right decision for a tolerable amount of risk in year one, and it goes poorly, but they did still make the right decision. In year two, they're less likely to make the right decision again. They will likely be more conservative because of the recency of, well, this freak accident happened last year, against clinical practice, against what people would say is an acceptable amount of risk. Something bad happened to have happened, and this happens because it's not perfect.
So you're saying that this unconscious bias of having a bad outcome makes you gun shy, to use a metaphor, for years to come. That one bad outcome will influence you on an unconscious level well into the future.
Absolutely. And it doesn't necessarily have to be your bad outcome. It could be the bad outcome of a trusted colleague. It could be the bad outcome of somebody else, or a particular journal, or a particular case study that you read that went against the defined convention. So the models that have been...
So then there's this bias around where I'm sorting for things that can go wrong, as opposed to seeing that in more of a balanced, that could go wrong, and the probability of that, or the applicability of that, is X or Y here. Did I summarize that right?
That's right. So those are the two clinical decision-making biases that happen here. There's also an environmental bias that I'd like to bring up as well. Certainly well established in the literature for organ transplant specifically is the weekend effect, and the similar organs and recipient combinations of potential organs for transplant for potential recipients that are offered on the weekend versus weekdays. In the case that a similar combination happens during a weekday, it's more likely to happen and be accepted than a similar combination happening on the weekend. And it has to do with all sorts of different environmental factors. But the end result is there's a statistically significant increase in the number of organs that are accepted during the week than the number of organ transplants that are happening on the weekend, controlling for all of those other variables that I mentioned before, as far as matching and how good the organs are predicted to last.
Does in terms of the cognitive biases in clinical decision making, to what degree does decision fatigue play a role here?
In the last 5 years, since the new kidney allocation system 2014 went into effect from the United Network of Organ Sharing and the Organ Procurement Transplantation Network, greatly increased the allocation, the national allocation of kidneys across previous state, local, regional boundaries. And this was in an effort to get better matches to people that had particularly high panel reactive antibodies to provide better matches, 6 antigen matches and longevity.
Yeah.
But
so
the result,
in effect, transplant surgeons were forced by this new rule to consider a significantly 10 times more potential organs, because it said we are no longer sourcing or procuring these organs within your service area, but in fact across the nation.
Absolutely. And we can see that shown in the data, number of offers for each organ that are made available since 2014. And it's been exponentially increasing year after year with the number of organs that are available nearby as the transportation and preservation of organs out of the body get to be more sophisticated. In the case of kidney, it's up to 30 hours of cold ischemia time. Livers can be up to 12. Hearts and lungs are still relatively very short, 4 to 6 hours out of the body on ice. So they're still limited geographically significantly. But for a kidney, they can be transported from any corner of the country to the other, depending on where the best match is or where there's an accepting surgeon. Unfortunately, fortunately, it does provide better matching opportunity. Unfortunately, the human logistics intermediary results in a much slower decision-making process, many more organs expiring on pumps or on ice and being discarded instead of being used for transplantation.
So again, the idea of decision fatigue is that each decision consumes a certain amount of glucose in your brain, and that as the day grows long, we tend to make less deliberative decisions, less reflective decisions, and decisions that are more kind of reflect cognitive biases than really kind of fighting fighting for perspective. So in the context of clinical decision making for organ transplants, one is just kind of the length of the day, the number of decisions, and also what you were just mentioning. Can you summarize that for us in terms of how this shows up and what OmniLife is doing to kind of offset that?
So clinical decision fatigue in the case of organ transplantation has been increasing year after year since the new kidney allocation system allocation model, and it will also increase with the new liver allocation model, where many more organs are being considered for any single recipient, regardless of their location in the U.S., regardless of the resources of their center. The transplant clinical team will be bombarded, using an active verb there, but bombarded with many more offers than they're previously had been expecting. And despite the number of offers increasing significantly, or potential offers increasing significantly, the staffing at the the transplant center teams and clinical teams has not been increasing like that. So from a manual sense, they're spending so much more time deciding and tracking down all the different variables and data and accumulating all of that information only to make a no decision, to shut the door and decline a particular offer, only to invite another offer right through the door again. And in many times, considering multiple offers at any one given time. And as you stated before, the state of affairs from a clinical or from a decision making or physiological glucose expenditure per each of these decision makings leaves somebody at risk to significant cognitive biases that we talked about before. And what OmniLife is doing to help alleviate all of this wasted decision energy is to help make the decision easier by giving only what the doctor needs to know at the time to make the decision, right in the palm of their hand and easily accessible, to easily match up the risk associated with the recipient, the risk associated with the donor, how long it's going to last, and the risk associated with the logistics involved with actually going to Maine and grabbing the heart and bringing it back to Los Angeles, for example.
So we have talked about that in the past in terms of perspectives, heuristics, and protocols, and expanding the number of perspectives with respect to a particular offer, and augmenting the heuristics or decision-making shortcuts, and then also making sure that they're embedded in the clinical protocols as supported by the current state of the practice. Can you expand on that?
Absolutely. So what OmniLife has done is we've worked very, very closely with the transplant centers that are our early customers and early supporters, also with some of the most prestigious transplant surgeons in the country, and clinical decision-making experts to design a workflow with TXP Chat, which is our secure mobile communications that handles all of the logistics. And we embedded the predictive analytics engine directly into the primary form of communication during an organ offer and an organ transplant. So when an organ becomes available, the free text and all the raw data are flowing through the secure HIPAA-compliant communication channels facilitated by TXP Chat, and then the predictive analytics. You don't need to lift a finger. They're being automatically calculated as the information is being added, despite not everything being available all at once. But as things flow through, they continue to optimize and continue to provide an enhanced directive as far as the predicted level of graft failure or graft success at a certain time point, 5 years, for a particular patient. So while an offer is under assessment, there's no need to open another screen. There's no need to consult somebody new and different. It's all right in front of you, actually in the palm of your hand. You don't even need to sit down and go to a computer, and you can have that guidance right there.
And as I understand the mechanics or the actual user interface of TXP Chat, is that each thread constitutes a separate case, and so what we're talking about is case management, smart adaptive case management vis-a-vis this mobile and desktop app. Can you expand upon the notion of adaptive case management, where all of this is all the essential decision-making resources are in one place?
So that kind of goes to our previous conversation about interoperability, but the accessibility to the actual patient data records through or being mobily accessible right on the app from the patient or the recipient side, and then the complementary data set from the these are both static data sets made streaming through the mobile application, so that there's so that we can use both data sources, and the data sources can be updated without kind of an update and a call and a push. They're streaming in, so as the updates come, they're immediately rectified with the new value, and also the data that are collected simply from a logistical standpoint in real time directly on the application, being locations for everybody in real time, locations for the organ, locations for the clinical teams, locations for the recipient team. The recipient may be 4 or 5 hours away from the hospital, or the recipient may be halfway through a 6-hour operation that needs to happen before the transplant or before the organ comes through the door and is ready for transplant. And a few other, in some cases, a patient with pre-existing conditions, or these are very sick patients that may have been through multiple surgeries, and the surgical operation before an organ actually comes through the door and is ready to be transplanted needs significant coordination as well. Certainly there are applications for all sorts of complex care, surgical operations and other things in other areas of healthcare, not just organ transplant. Organ transplant happens to be one that's particularly difficult.
So as you're describing TXP chat here, it strikes me it's way more than just a secure chat application, and that it's really more about coordinating care and around a case. So it's almost case-based care coordination. Did I get that right?
Absolutely. It aggregates all of the information, the real-time information about a particular patient case, in this case, a transplant operation, and an organ that needs to come in, a recipient that needs to be mobilized and sent in, and then many, many different clinical teams and laboratory, specific serology labs and laboratory technicians and medical couriers and other many different moving parts that need to be coordinated together are all aggregated in one place with the analytics behind them to provide enhanced visibility and transparency to the entire process, circumventing many, many different phone calls to different teams in order to try to make sense of where everything's coming and if everything's going to come together or not.
Cool. And in the time we have remaining, could you kind of expand upon, you've introduced the notion of predictive analytics. Could you expand upon that in the context of clinical decision-making and perhaps talk about data mining and model building?
Absolutely. So what we have access to are models that are well established in mathematical journals, computer science journals, bioinformatics journals in the lab that do an excellent job of characterizing and predicting different disease states and how and predicting how long different situations will last for in all different areas of healthcare. And certainly organ transplantation is not something that has been ignored for these predictive models. Primarily, we have approached forecasting clinical outcomes in organ transplant using a Cox hazard regression model, which uses time interval follow-ups for transplant patients over the past 30 years, and following the patients that have been successful and patients that have seen failure, and has been marking many of the values at each of those follow-ups, and then as well as the values that were captured at time of transplant. And these linear models have been significantly acutely focused on a few variables that are independently statistically significant to those endpoints, which is excellent and makes the model very straightforward and very easy to interpret from a clinical perspective, from a non-statistician, biomedical informatics perspective. But we are losing the information from about 780 more variables that could be incorporated in this model, and a number of many hundreds of other variables that are associated with the logistics, purely the logistics around each of these information, or each of these patient cases, in this case for transplant. So what we can do with machine learning models is we can use all 1,000 variables that are available at time of transplant, and we have the previous data of the follow-ups and of when those patients expire, but we can use even more variables at the beginning to forecast whether they will be successful or not successful at 5 years past their transplant, for instance, and utilize all of those other variables, including genetic information, including behavioral and behavioral and dietary, patient history, all sorts of other things that were not previously included in the linear models that were used before. We also have the ability to validate those models on the very data that they're used to validate the linear models, or the very simplified, very acutely focused linear models, to compare them and show that incorporating more of these variables can help make a better prescriptive assessment of the risk associated with transplanting the organ, or waiting for the next organ offer for that particular donor and recipient transplant operation.
Cool. So last question then. What do you envision? How do you envision the OmniLife platform evolving to support the care continuum of organ transplant recipients?
First off, I'm going to touch on something that I didn't describe before, and that is how we're going to actually implement a randomized clinical trial for this clinical decision support at time of organ offer, and then how we will use that to influence the rest of the care continuum. But the first thing is, we are working with University of California, San Francisco, University of Pittsburgh Medical Center, University of Iowa, University of Minnesota, and a number of other significantly academic and research-focused institutions to design a randomized controlled trial for the use of clinical decision support during time of organ offer. And the way we've laid it out thus far, or templated it out, is that when an organ offer becomes available through TXP Chat, it will be either assigned a control group or an intervention group with respect to receiving predictive analytics during that organ offer. And from there, after 100 organ offers, we should be able to show the difference in how the biases were corrected based on having analytic information at that time versus when they received a placebo. And we can characterize, or we can produce a scientific causal, or we can validate a causal relationship between having predictive analytics at that time and the more successful rate of transplants associated with a better risk, a better risk assessment during organ offer, being that we've accounted for the previous biases that we've talked about before, and doctors are actually making more rational, better decisions.
And this is a NIH funded study?
That's right. We all the previous academic institutions that I talked about wrote letters of support for our SBIR Phase 2 clinical trial to the National Institutes of Health
to validate the predictive analytics of TXP Chat in producing superior patient outcomes.
That's right.
Cool.
So how that transcends into the.
I've just got
how that transcends.
Go ahead.
How that transitions into the end of the entire comprehensive care network is through data about the recipient well in advance of that day of organ transplant. We're going to be working with the data that the the patient has when they're first diagnosed with their organ failure, working with the transplant centers that they see when they get waitlisted, as well as the intermediary treatment options that are available, such as dialysis centers that see them 3 to 4 times a week, getting updated laboratory results and receiving dialysis in this case. And then afterward, making sure that we handle behavior and medical adherence post-transplant to optimize for the longest successful outcomes we can for the people that do receive their transplants and so forth, whether that be hydration, exercise, diet, and then of course taking Prograf or anti-rejection therapy medication. So
Cool.
that's it. Thank you.
What a great place to end.